The primary endpoint was mortality at 28 days and 90 days. And in fact, they did not find any difference in mortality out of their 800 plus patients between those patients who were maintained at a hemoglobin of 7 to 9 with a transfusion threshold at 7, and those in whom they maintained a hemoglobin of more than 10 and the threshold for transfusion was 10 grams per cent. They did subgroup analysis as well from this study. In fact, they found that in less severely ill patients with an Apache score of less than 20, first. Secondly, in younger patients of age less than 55 years, there was a reduced mortality compared to patients who had a higher severity score and in those who were in a higher age bracket. So this was as I mentioned, one of the landmark papers in our specialty, published 20 years ago. In fact, the study was done about 25 years ago. So that's a long, long time. Do we still follow the TRIC guidelines? Do we still do the same things that the TRIC trial told us to do 25 years ago? This is particularly in the face of two things. Firstly, if you look at the TRIC study itself, it said less severely ill patients, younger patients do better, survive better, at least on subgroup analysis. So does the corollary hold true? Would mortality be, if patients with a higher severity score are transfused earlier, would they survive better? First question. Secondly, leukoreduction was not very common at that time, and this study was done on non-leukoreduced blood. Since then, many countries have adopted the leukoreduction strategy, and the question naturally arose, would the transfusion of leukoreduced blood make a difference to these numbers that they cite? In other words, do we have some new tricks to play apart from the TRIC trial back 20 years ago? The leukodepletion of blood results in a number of favorable effects, common ones being reduced incidence of reactivation of viral diseases, reduced immunomodulation, reduced reperfusion injury, and also reduced incidence of non-hemolytic transfusion reactions. So these are some of the advantages which occur with leukoreduced blood, which may have made a difference over time compared to the historical study that we cited. Besides, many facets of intensive care has changed over time, and would they all make a difference to the way we think in terms of transfusion thresholds? And also, as the topic itself suggested, should we use one threshold for all patients, or do we need to tailor the threshold depending on the type of patients that we see in the ICU? Does it really matter? We see septic patients every day. The focus of this whole conference has been sepsis for most part. So the question naturally arises, would the transfusion threshold of 7, as suggested by TRIC, hold true in septic shock? Emmanuel Rivers, in his protocol many years ago, again, almost 20 years ago, he used a bundle of measures, including transfusion to a hemoglobin of 10 grams per cent or a packed cell volume of 30%. So that was one of the measures that he used, apart from several others, such as mean artery pressure, central venous pressure, and so on. So I must point out that at this time that Emmanuel Rivers did this study, the TRIC paper hadn't actually been published, although the study was going on. So he didn't have access to the information that we subsequently had, saying that a threshold of 7 or higher may be okay. So that's why perhaps he used a threshold, a physiologically good sounding threshold of 10 grams per cent and a packed cell volume of 30%. Subsequently, More recently, in 2012, this paper again looked at patients with septic shock. They did not do a randomized controlled trial, but they looked at a cohort of patients and tried to match them into pairs based on their baseline severity in a propensity matched analysis. And they found that in those patients who had transfusions in sepsis and septic shock, the mortality was lower at 30 days. So that was again some suggestion that more recent data may suggest at least no harm from transfusion. So it is against this background that we had this very definitive randomized controlled trial published just a couple of years ago for patients in septic shock. The thresholds were very similar to the TRIC trial. Low threshold was 7 in one group, and in the other group they were transfused for a target of 9 of hemoglobin in septic shock patients. And here again they found, as against 1 packed cell transfusion in those patients in whom they had a restrictive strategy. They had to use 4 transfusions at an average in patients in whom they aimed for a higher hemoglobin. However, the incidence of mortality was no different between these two groups, regardless of whether the hemoglobin was 7 or higher, or on the other hand, if it was 9 or higher. So in effect, it essentially showed that in patients with septic shock, a lower transfusion threshold of 7 grams per cent may be appropriate. Secondary endpoints included number of days on vasopressor, number of days on ventilation, number of days on renal replacement therapy as well. And none of these endpoints also differed between patients who had a liberal strategy versus those who had a restrictive strategy. They did subgroup analysis on patients who are older, patients with cardiovascular disease, patients with a higher severity score. Again, there was no discernible difference between groups in these subgroup of patients. So, for all intents and purposes, that more or less answers the question, what should be the threshold in a patient with sepsis septic shock? It is probably 7 grams per cent. There is very strong evidence today in the form of randomized controlled trials that suggest that 7 may be appropriate for septic shock. Now we go on to cardiovascular disease. That has been always a bit of a dodgy situation. In fact, the TRIC trial itself had a relatively small number of patients with cardiovascular disease. 20% was the number they had. In the TRIS trial, which is the septic shock trial that I mentioned, there were 14% of patients who had incidental cardiovascular disease. And there was always a question as to, in patients with acute ischemia, acute coronary syndrome, or unstable angina, should you aim for a higher hemoglobin level? It makes sound physiological sense to do so because, as you know, the compensatory mechanism in anemia is for the heart to increase the cardiac output by increasing the heart rate and the stroke volume. This obviously entails more oxygen demand for the heart. And if you cannot supply enough oxygen in terms of enough hemoglobin and saturation of hemoglobin, then you might argue that it might affect heart function adversely. Unfortunately, there are no trials which have looked at acute coronary syndromes like the way we have in septic shock, like I mentioned. And to add to this problems is the fact that acute coronary syndrome in the critically ill patient in ICU with other conditions such as sepsis is often very hard to diagnose. Many of them are on ventilation sedation. You cannot communicate, they cannot communicate with you. They may have chest pain, may not be able to tell you. ECG signs in a patient who is tachycardic, otherwise septic, may be not very obvious, not very easily identifiable. Troponin levels may be high due to other reasons as well, sepsis itself or acute kidney injury that happens very often in sepsis may also cause your troponin levels to rise. So obviously, there is a bit of difficulty there in identifying acute coronary syndrome in patients who are critically in ICU due to other reasons. So we do not have randomized controlled trials that have addressed this question. Meta-analysis have been done which have included patients with several other incidental diseases such as oncological problem, elective vascular surgery, orthopedic surgery, upper GI hemorrhage, patients with hip fracture and so on. And in these, this is the most comprehensive meta-analysis that I could come across on my literature search, which in which they looked at this composite outcome of myocardial infarction, acute coronary syndrome and cardiac arrest as a composite outcome. And when they looked at all these studies which I mentioned previously in different subcategories of patients with different illnesses, the incidence of cardiovascular disease and the use of a restrictive strategy aiming for a lower hemoglobin level was associated with an increase in adverse events of infarction, acute coronary syndrome and cardiac arrest. So there is some signal there from this meta-analysis that suggests that in patients with incidental cardiovascular disease, you might need to aim for a higher hemoglobin level. Unfortunately, as all meta-analyses go, these studies use different hemoglobin levels as a cutoff for transfusion. There is no single uniform number that you can point at. However, perhaps it is very important to consider transfusion in patients with incidental cardiovascular disease at a slightly higher hemoglobin than the 7 that we seem to agree for sepsis and septic shock. Moreover, mortality may not be the only appropriate endpoint in anemia. Health-associated quality of life may also be an important factor. Patients with anemia have worse outcomes with cardiac failure, worse outcomes with exercise tolerance. So all these things may also not matter, and perhaps you shouldn't aim for only mortality as an endpoint. Neurological disease is another area of some doubt as to what may be an appropriate level of hemoglobin. As we saw in big major randomized controlled trials across the board, you might not find a difference. But if you confine yourself to specifically neurological states, would there be a difference? Do you need to adopt different thresholds for patients with neurological problems? When there is anemia, how does the brain respond? The first response in the brain as the hemoglobin drops is an increase in the cerebral blood flow in a proportionate manner till a hemoglobin of about 5.5 is reached. Till that point is reached, the blood flow goes on increasing to compensate for a drop in hemoglobin. After that, the blood flow reaches a plateau. So the oxygen delivery is maintained by an increased blood flow till a hemoglobin of around 5.5. These are in normal subjects or normal animals. These are not in patients who have neurological injury. And beyond or below that level, damage is possible. Now you must consider that brain injured patients do not have normal neurons. Their neurons are dying or on the verge of dying, and perhaps you might argue that a lower hemoglobin may be adequate for normal physiology. But those cells are on the verge of dying in the brain, especially given the fact that brain cells are very, very crucial in their requirement for oxygen. Would it really matter if you bring down the hemoglobin to a lower level? If you look at evidence, specifically these areas have been tested. Traumatic brain injury, which is very important to us, ischemic stroke, which we deal with occasionally in our ICUs, and subarachnoid hemorrhage specifically. In subarachnoid hemorrhage, there is a low level evidence that suggests in this particular study that if the hemoglobin drops to below 9 grams %, there is an increased odds of poor outcomes at 3 months as measured on a Glasgow outcome score. Outcome score 4 to 6 means death or severe disability. So So perhaps in subarachnoid hemorrhage, you should aim for a hemoglobin of more than 9 as we stand today, going by the evidence we have at this point of time. In traumatic brain injury, again, this question has very often been raised. Many neurons have died, many of them are on the verge of dying. Should you aim for a higher target? This particular study, which combined 3 randomized controlled trials, again showed worse outcomes in patients who had a lower hemoglobin. Again, the number as to what may be an appropriate level is not clearly answered. Similarly, in acute stroke as well, in this study in which the authors did a cohort study plus a systematic review, it seemed to suggest that low hemoglobin levels carries with it. Low hemoglobin levels in this particular study meant they took anything below normal level as low. In the male it was 14 to 16, and in females it was 12 to 15. Anything below that was considered low. And they found that outcomes in terms of Glasgow outcome score were worse off in acute ischemic stroke in anemic patients. So there again, even though you do not have absolute numbers to go by, it seems to suggest to us that the hemoglobin level of 7 that we use for sepsis and other generally critically ill patients may not hold true for acute ischemic stroke. And when you deal with the brain, perhaps it also makes sense, this I must admit is not based on evidence, it perhaps would make sense to evaluate your patient comprehensively in terms of their wakefulness, in terms of the extent of the injury that they have suffered. And obviously, if they have suffered more severe forms of injury, as in a very high-grade traumatic brain injury or a high level of stroke, perhaps you would always aim for a slightly higher level. And then maybe the time will come when we will depend on, not on an absolute number of hemoglobin. Perhaps we would depend more on brain tissue oxygen saturation, or maybe cerebral microdialysis, lactate levels, jugular venous oxygen saturation. These may be better endpoints, more definitive endpoints than going by a number of, say, 7 or 9. So, to sum it up, we definitely do not contradict the evidence produced by the TRIC trial. Across the board, a threshold of 7 may be a rough ballpark number. There may be subgroups of patients in whom you might need to aim for a higher level. Cardiovascular disease is an obvious reason to transfuse at a slightly higher hemoglobin level. Patients with severe neurological injury or impending neurological injury may also require higher hemoglobin levels as well. So it really boils down to specific clinical situations and based on the experience and evidence that you accumulate over the years as you stand by the bedside to decide what is appropriate for my patient. Thank you.